Sir, we are live now. With all your permission, I'm starting
Why?
this session.
Why? Stop.
Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. C. Sarath Kumar, sir. And let me share some of the achievement of sir. Sir has done MBBS, MS from UK, DRCOG from UK, and PhD, and super specialist in sexology and infertility, and at Dr. Sharath's Men's Clinic, director at Mediwave Fertility Research Hospital. And today he is going to speak on a topic ejaculatory disorder and their management. By taking not much time, I would like to invite sir and hand over the session to sir. Over to you, sir. Kindly proceed from here.
Good evening, all the doctors. I'm extremely happy to be here again along with you. I sincerely thank Faraz for a nice introduction. And also, I think I sincerely thank IJCP authorities for giving me an opportunity to address you. Today, the topic is very, very interesting, ejaculatory disorders and their management. It is not that easily discussed elsewhere. We discuss so many other factors like erectile dysfunction and other disorders, but not that frequently ejaculatory disorders. So, what is this ejaculatory disorder? Ejaculatory dysfunction is one of the most common sexual disorders. The spectrum of EDY includes premature ejaculation, delayed ejaculation, anejaculation, that is no ejaculation, retrograde ejaculation, and painful ejaculation. So, there are 5 spectra of ejaculatory dysfunctions. Premature ejaculation I have already covered, so I will not go into the details of premature ejaculation in this lecture. Those who want to see the slides of premature ejaculation, you can contact the IJCP. They will send you the link of my previous lecture on premature ejaculation. I will not repeat it. Today I am going to cover delayed ejaculation, and if time permits, then only I will go for the other anejaculation, retrograde ejaculation, and painful ejaculation. Otherwise, I'll take this opportunity to go into the details of delayed ejaculation in this lecture and reserve the other 3 for the next few lectures, that is next few weeks. So those who want to go through the slides of premature ejaculation, kindly contact the IJCP, you will get it. So let me introduce the subject. Ejaculatory dysfunction is a common complaint and is often associated with a reduced quality of life for sufferer and partner. The spectrum of ejaculatory dysfunction extends from premature ejaculation to delayed ejaculation, anejaculation, painful ejaculation, etc. Over the past 20 to 30 years, EDY treatment, pedigram, previously limited to behavioral psychotherapy, has expanded to include so many drugs. More recently, there has been increased attention to psychological consequences of premature ejaculation and its epidemiology, its etiology, and pathophysiology by both clinicians and pharmaceutical industry. Delayed ejaculation and anejaculation are probably the least common, least studied, and least understood. So, friends, I'm going to touch upon the second paragraph, that is the delayed ejaculation. Later on, if in the next few lectures, I'll touch upon the anejaculation and painful ejaculation. So their impact is significant as they might result in a lack of sexual fulfillment for both man and his partner, and effect further compounded when procreation is among the couple's goals of sexual intercourse. So let us touch upon the anatomy and physiology of ejaculatory response so that we will understand much better the delayed ejaculation later on in this topic. Ejaculatory reflex comprises sensory receptors and areas, afferent pathways, cerebral sensory areas, cerebral motor centers, spinal motor centers, and efferent pathways. So the signals go from the various parts of the body, including the penis and the surrounding areas, and it goes to the cerebral sensory areas, then to the cerebral motor system, and then it comes to the spinal motor centers and efferent pathways. So this is the chain of reaction of the physiology of ejaculatory response. Neurochemically, this reflex involves a complex interplay between central serotogenic and dopaminergic neurons with secondary involvement of cholinergic, adrenergic, generic, and gamma aminobutyric acid neurons. So, friends, two things are involved. One, the sensory nerves, afferent and different, and neurochemicals also, out of which serotonin, which inhibits emission, ejaculation, and dopamine, which promotes seminal emission and ejaculation, have emerged as key neurochemical factors. That is, we have serotonin in one end and dopamine in another end. So, serotonin inhibits the emission, and dopamine promotes the ejaculation. So, we have two neurochemicals here. So today I'm going to talk about delayed ejaculation in the next 45-50 minutes or so. So I'm going to cover this with introduction, definition, incidence, causes, risk factors, investigations, treatment, side effects, and conclusion. So coming directly to the topic of the day, delayed ejaculation. What is delayed ejaculation? It is also sometimes called as impaired ejaculation, inadequate ejaculation, inhibited ejaculation, primary impotentia ejaculation. So many other synonymous terms are used, but I will restrict myself for the DE, that is delayed ejaculation. It's a condition in which it takes an extended period of sexual stimulation for men to reach sexual climax and release the semen from the penis, that is ejaculation. So this person is going to ejaculate, but is taking undue, unwanted amount of time, which is not pleasurable many times to himself or to the partner also. So delayed ejaculation is a condition wherein ejaculation, which should have occurred at the time of climax, has not yet occurred, and man struggles to achieve the climax. That is delayed ejaculation. That is involuntary. That is wantedly delaying the ejaculation by using so many methods of tablets, injections is different. But this delayed ejaculation is pathological. He wants to ejaculate, but is unable to ejaculate. So that is the deal. And it has been used as a marked delay to achieve ejaculation. The may occur during self-masturbation or manual or oral or vaginal or anal stimulation by the partner. So any type of sexual activity the person is involved, and if he is unable to reach the climax during the stipulated time, it is called as delayed ejaculation. Some men with delayed ejaculation are unable to ejaculate at all, then it will be called as unejaculation. I am not going to cover the unejaculation part in this lecture. I limit myself to the delayed ejaculation. So, unejaculation is where the person never ejaculates, but delayed ejaculation is where the person ejaculates, but after a long time. In the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the definition of D requires at least one of the two symptoms, either a marked delay or a marked infrequency of ejaculation on 75 to 100% of occasions for at least 6 months of partner sexual activity without individual desiring delay and causing significant distress to the individual. So, two things are required. One, this should be recurring more frequently. Once in a way, if a person doesn't ejaculate, then it is not called as DE. It should be repetitive, and it should be occurring from past 6 months, and it should be causing significant distress to himself or to the partner. Despite the confusion in terminology, men diagnosed with DE experience difficulties in ejaculation and orgasm. Is often quite concerning to patients and their partners, and sometimes frustrates the couple's attempt to conceive also. So the picture of infertility also comes in the definition of the DE. What is the pathophysiology behind this one? The literature suggests that pathophysiology of DE is multifactorial, including both organic and psychosocial factors. Despite many publications on this, the exact pathogenesis is not yet known. There is currently no single gold standard for diagnosing DE, as operationalized criteria do not exist. The history is the key to diagnosis. Treatment should be cause specific. So, friends, the diagnosis is written on the face, on the forehead of the person himself. He comes and declares that he is unable to ejaculate for a period which he requires. That is, one may say that 10 minutes is the DE time. Another may say 20 minutes. It is subject. So if the person has got distress out of DE, then it is called as DE. There are many approaches to treatment planning, includes various psychological interventions, pharmacotherapy, specific treatments for infertile men, an approved form of drug therapy does not exist. So, etiology and pathophysiology. Ejaculation involves emission, bladder neck closure, and expulsion. That is ejaculation proper. In emission, seminal fluid is delivered to the posterior urethra. Sympathetic innervation T10 to T12, L2 controls the emission as well as contraction of the bladder neck to prevent retrograde ejaculation. During expulsion, pulbocavernous muscle synchronized with the pelvic floor muscles contract to expel the semen in an antegrade fashion through the anterior urethra. Somatic innervation S2 to S4 mediate the process. Generally, this reflex is controlled by both somatic and somatic neural inputs as well as sensory inputs. Many neurotransmitters such as serotonin, dopamine, and norepinephrine play an important role in the ejaculatory physiology. Orgasm is purely cerebral experience that usually but not always coincides with ejaculation. What is the etiology for DE? For many years, different views have existed regarding the etiology. On one hand, it was argued that DE may be caused by psychosexual, psychosocial, and relationship problems. On the other hand, it has been argued that DE is caused by genetic, neurobiological, endocrine, anatomic, infection disorders, or maybe drug use. So, multiple factors have been involved. Many of these etiological factors are not supported by good evidence-based data, but rather based on case reports. So, friends, DE is not widely studied. In fact, the ED, erectile dysfunction, and PE, premature ejaculations, have been studied so widely, but DE has not been studied in depth because the number is less. These etiological factors, organic and psychogenic etiologies, are neither independent nor mutually exclusive and may well interact with each other, and their pathological effects may vary between the individuals. Coming to psychogenic factors. Insufficient sexual stimulation, mental or physical, that is one theory. This theory was proposed by Masters and Johnsons, and you know who Masters and Johnsons are, and as well as from the Bancroft also. This theory perceives D as being due to insufficient penile or mental stimulation, often associated with aging or diminished penile stimulation. The main prediction of this theory were supported by findings from the multiple studies. And they have reported that no apparent somatic etiology and experienced less sexual arousal than the men. So, the main factor blamed for DE is insufficient sensation or insufficient stimulation. This is one theory. Another study performed an analysis of data of 206 patients who experienced delayed orgasm, noted abnormal penile sensation in 7%. That is, as I told you earlier, when I was describing the pathophysiology of the DE, the sensation should go from the penis. And if there is no good sensation, then the penis has become numb. It is not sending the signals to the brain, and the brain is not releasing the dopamine, and the ejaculatory process is not occurring. That is one theory. Additionally, another scientist noted that patients with primary DA appear to have penile shaft rather than glands hypersensitivity and hypoexcitability. That is, the sensation in the glands and the shaft are less. And another study confirmed that penile vibratory stimulation could adequately treat 72% patients with secondary DE and orgasm, indicating that the penile vibratory stimulation may initiate normal ejaculatory reflex. So this treatment with penile vibratory stimulation shows that If you stimulate the penis properly, he will ejaculate. That shows that it was inadequate sensation or the response from the glands, which is the cause for the D. Unusual masturbation patterns and fantasy life is another factor. This theory stated that some men with D tend to prefer unusual methods of masturbation over heterosexual intercourse with their partner. The factors that disproportionately characterize patients with DE: high frequency masturbation, idiosyncratic masturbation style, disparity between the reality of sex with a partner and their preferred masturbative fantasy. So, some men are used for masturbation in certain angle with fist or with a pillow, with some angle and with some speed. And only when they reach that speed, that momentum, that environment, they are going to ejaculate. And if that is not achieved, that is from the partner, that is by using the mouth or vagina or the hand, he may not ejaculate because the penis is not used for that speed, momentum, and that trajectory and that environment which he was used for so long time. So, unusual masturbation patterns and the fantasy, that is, while masturbating, he would have been used for some fantasy, using imagining some heroine or some girlfriend or some other XYZ. And when that is not occurring with the partner, then he is unable to ejaculate. Only when he goes to that fantasy life, he is going to ejaculate. Another theory, psychological theory, the concept of third psychological theory was posted by another scientist. It conceptuates D as a subtle and disguised sexual desire disorder masquerading as DE. According to this concept, these patients mainly prefer solo masturbation rather than partner sex. So they will be very happy with masturbation, not with the partner sex. Another theory is psychic conflict theory. This theory, as an outgrowth of psychic conflict, making psychodynamic in origin, following conflicts have been reported: different types of fear, hostility towards one partner, unwillingness to give oneself, and guilt from strict religious upbringing. So these are all the conflicts which are going on inside the mind of the person who has got the D. Other factors like organic factors, congenital abnormality, bent penis, or the Peyronie's disease, or fibrosis in the penis, no sensation in the glands, medical diseases, surgical procedures, drugs that interfere with either central control of ejaculation or the peripheral control that includes sympathetic nerve supply to the vas deferens, bladder neck, prostate, seminal vesicles, as well as the somatic efferent nerve supply to the pelvic floor can result in DE and also sometimes anorexemia. So any medicines, any drug which interferes with this afferent and different pathways of the penile sensation and ejaculation will definitely cause DE. Other factors like age, congenital abnormalities, genetic factors, neurogenic factors, infections, inflammations, endocrine disorders, pharmacological causes may also have a role in the DE. Aging is a very, very important factor. An age-independent increase in the prevalence of DE was reported by various studies. This finding may be related to decreased penile sensitivity to age, which has been attributed to possible ultrastructural or degenerative age-related changes in the penile receptors, leading to progressive axonal sensory loss. Additionally, some researchers have hypothesized that DE is caused at least as part by slower bulbocavernous reflexes and reduced spinal stimulation associated with aging. Despite these age-related changes, another study failed to show significant correlation. So, friends, age is a very, very important factor. In fact, age will affect all the sexual functions, including the delayed ejaculation, erectile dysfunction, and other painful erection. So many other factors, loss of libido, loss of desire. All these have been attributed to aging. So aging is one of the main factors for DE. And other factors like depression, diabetes, comorbidities, late onset hypogonadism, radiation therapy for number of age-related diseases can affect the ejaculatory function and result in DE. Genetic factors, D is marked by etiological complexity and range of severity of DE even up to AE, that is anejaculation. In addition, ejaculatory latency is greatly variable. And these findings have led to the hypothesis that genetic factors can affect a person's predisposition to the DE as well as AE. Another scientist documented that single nucleotide polymorphism, that is SNP, in the gene encoding the receptor showed an association between intra-ejaculatory latency period, indicating that individuals homozygous for the G allele had shorter IELT, were conferring protection against the DE. So genetic factors have also been blamed for DE. Neurobiological changes, another study introduced a dynamic neurobiological theory of PE and DE. According to this, ejaculation disturbance theory, lifelong DE as well as PE is considered to be part of normal biological variability in IELT. It is postulated that any random sample of men is likely to include a minority of men, always easily early ejaculation, and a second minority who will have DE. The findings significant variability of intravaginal ejaculatory latent time values among the general population from 0.55 to 44.1 minutes. That is half a minute to 44 minutes. That is the intravaginal ejaculatory period recorded in a study. Genetic factors I have already told. Other factors include multiple sclerosis and diabetes mellitus and the other masturbation related disorders. The most common of these, the NAER, retroperitoneal lymph node dissection, that is surgery, and sclerosis, which jointly occurs for almost 90% of the cases. So these are the other factors of the infection is another one condition which may cause erectile dysfunction, PE, painful ejaculation, as well as delayed ejaculation. However, there is no definitive evidence of actual frequency of DE in patients with urogenetical infections, but it may play a role. There are some other factors, hormonal factors, disorders affecting the level of testosterone, prolactin, thyroid hormone have been associated with the DE. Testosterone appears to play a facilitated role in the control of the ejaculatory reflex, but estimated ejaculation time during vaginal intercourse or masturbation were not associated with serum T levels. So there is no direct correlation of the hormones on the DE. There is weak evidence association between hyperprolactinemia and DE. In contrast, hypothyroidism was strongly associated with DE. So hormonal factors are not that definite other than hypothyroidism. Coming to medications. Complaints of DE in patients taking medications are not uncommon. Different medications may interfere with their central or peripheral control of ejaculation, potentially affecting the IELT. Pharmacological agents that have been associated with DE include tricyclic antidepressants, very, very important, SSRIs, monoamine oxidase inhibitors, that is selective serotonin reuptake inhibitors, monoamine oxidase inhibitors, neuroleptics, diuretics, narcotics, alpha-1 beta blockers, anti-epileptics, 5-alpha reductase inhibitors, alcohol, and others have been blamed to result in DE. The literature suggests that DE is an almost commonly reported sexual dysfunction associated with antidepressants use. Other frequently reported problems include delayed or absent orgasm, reduced or absent sexual desire, and ED. So, mainly these antidepressants are very, very important drugs which results in so many types of sexual dysfunctions, including DE. Coming to diagnosis, there is currently no gold standard for diagnosing DE as operationalized criteria do not exist because many organic and psychological factors may be involved in pathogenesis of DE. A careful clinical history and appropriate physical examination should focus on all related symptoms and signs. The history is main for the diagnosis and, of course, physical examination. Coming to evaluation, evaluation begins by excluding retrograde ejaculation. The difference between retrograde ejaculation, unejaculation, and delayed ejaculation is in retrograde ejaculation, the patient ejaculates, but the semen doesn't come out from the penis. It goes back. It reaches the organ. Unejaculation, it doesn't ejaculate. Delayed ejaculation, he ejaculates, but late. Absence of puberty, genital tract obstruction, anorgasmia, and other sexual dysfunction may be misdiagnosed as DE, such as ED, supply decreased libido, ejaculatory pain, and partner's dysfunction, sexual orientation conflicts, and paraphilia inclinations and interests should be ruled out before labeling it as DE. So these are the differential analysis. They should be kept apart. It is important in the history to ascertain whether the complaint of concerns DE, sensation of orgasm, or both. Ejaculation occurs in the genitals, whereas orgasm is a central sensory event. Ejaculation and orgasm usually occur together, but not always. Sensation of orgasm in the absence of antegrade ejaculation suggests retrograde ejaculation. So, if the person attains the orgasm, that means he has ejaculated backward, that is retrograde ejaculation. The second step is to confirm the presence of DE by asking about duration of thirsting before suspension of intercourse, the ability to advance the ejaculatory response, and the level of distress or bother caused by the situation. Evaluation may involve determining whether DE is lifelong or acquired, global or situational. In the generalized form, lifelong or acquired, the history may reveal whether the patient is experiencing substantial delay or absence of ejaculation or some in all circumstances. In a considerable number of cases, DE, the patient is typically unable to ejaculate in the presence of a partner, specifically during coitus, but is able to orgasm and ejaculate during solo masturbation. If a man is only able to ejaculate through masturbation, it is important to assess whether he has idiosyncratic masturbatory style. The style has to be assessed. Men with DE have demonstrated high level of relationship distress, sexual dissatisfaction, anxiety about their sexual performance, and lower frequencies of coital activity than sexual function. Third step is to uncover the predisposing issues and potential risk factors that are believed to participate in the pathogenesis. A focused clinical examination, questionnaire, laboratory tests, and radiological imaging may help to for the diagnosis. A physician need to carefully balance the risk of missing serious causes with a wise use of scarce and costly investigation resources, especially in the developing countries. Sometimes the diagnosis of risk factors unfolds over time and across several episodes. In addition, etiological diagnosis process can also be extended across multiple specialties. Coming to treatment, defining firm recommendation to approach treatment of DE is difficult for a condition that is less common and heterogeneous, for which the literature is confined to case reports, case series, and small studies. So this limitation of knowledge about DE has made us to limit the treatment aspect because we don't know clearly what's going on. There are many approaches to treatment and planning. A rigid treatment plan is not suitable for all the patients and it should be flexible. Factors that affect the choice of treatment strategies may include clinical judgment regarding etiology of DE and making sound decisions. This implies active involvement of other specialties in the management of condition. Physicians' experience such as training in communication skills and management of sexual problems. These factors have been shown to affect professional behavior. These cases, treatment should not be cause specific. Neurogenic DE is usually irreversible, and thus patient might be counseled to seek alternative methods to improve patient and partner satisfaction. A positive chemistry reflex in patients with the SCI suggests that intact emission and patient should be encouraged to attempt ejaculation or to explore possible retrograde ejaculation. In a recent randomized control, 2% replacement of T solution was not associated with significant improvement. The number of approaches can be employed for infertile men. If the person has come with delayed ejaculation, landed up in infertility, then the treatment includes collection of nocturnal emissions, prostatic massage and getting the semen, prostatic urethra catheterization, penile vibratory stimulation, probe electroejaculation, sperm retrieval by aspiration from either the vas deferens or the epidermis, and testicular sperm extraction. So these are the treatment options available for person with DE or AE who has landed up in the infertility. The presence of co-occurring mental disorders, sexual orientation conflicts, unusual masturbation techniques, strong religious convictions, hostility, fears, relationship factors, and paraphilic inclinations and interest must be assessed because these factors may narrow the scope of possible treatment strategies and help the physician identify whether psychiatric care is needed. So the cause should be seen first. Consultation with gynecologist may have a significant impact on case associated with partner sexual dysfunction or other gynecological disorders, as DE may be triggered by the fear of hurting the partner or a decrease in the perceived attractiveness of the partner if she had mastectomy, hysterectomy, and other types of disfigurement. So the partner's attractiveness is also equally important in the management of DE. Fertility is an issue. It can be managed relatively effectively in cases of AE with collection of nocturnal emission, so on and so. Men of reproductive age should be informed the risk of infertility due to an ejaculation. Patient preferences are important considering the treatment of DE. Psychological interventions may be required. Paying special attention to psychogenic factors may additionally reinforce the therapeutic success of some patients. Many psychotherapeutic treatments have been described for the management of DE, addressing known suspected psychogenic causes. The management includes cognitive behavior therapy, masturbatory retraining and adjustment of sexual fantasies, psychotherapy targeting the areas of conflict and sensate focus exercises, altering one's orientation from oneself to one's partner, sexual anxiety reduction by teaching the individual mindfulness and breathing techniques, progressive relaxation, and increasing sensory tolerance. Couple sex therapy and use of interactional techniques, sexual tipping point model, which emphasizes the utility of a biopsychological, psychosocial, cultural perspective combined with social special attention to the patient's narratives. Treatment is patient-centered and holistic. Generally, these psychological manuals appear to be effective in case-reported cases. Coming to pharmacotherapy, attempts have been made to treat DE using off-label medications based on pharmacological and physiological consideration. However, an approved drug doesn't exist. So far, no real drug which has been labeled has come. These medications facilitate ejaculation by different mechanisms of action and have limited success and may lead to significant side effects also. So medications, given variety of drugs available for managing the DE, question of which to choose can be a complicated issue in clinical practice. The choice of drugs should be guided by etiological factors, illness characteristics, and patient's preferences, the clinical evidence, and physicians' comfort with the different drugs. It is known that response is relatively poor in neurogenic DE. Of interest is a recent single case report of successful oral administration of 60 mg lisdexamfetamide dimesylate. It's a very complicated drug. I don't know whether it has come to the market or not. I have taken it from the literature, from one of the research papers. So this drug, that is lisdexamfetamide dimethylcellate, producing, that is converted by the liver to the active dextroamphetamine, which is a non-catecholamine sympathomimetic amine 2 hours prior to the masturbation in a patient with neurogenic EE. So this has been reported, but it has not come to the market. I have just told you the name so that, yes, in future, this drug may come to the market. In contrast, recent double-blind control studies was including the placebo inducing antegrade ejaculation in patients with systemic sclerotic disease. For patients who suffer from antidepressants related, the shifting to another antidepressant such as bupropion or adding cabergoline if they have hyperprolactinemia may be most prudent option. So, friends, this is one important thing I would like to tell. If the patient is on antidepressant, whichever the antidepressant he has got, change it over to bupropion, which has got least side effect of DE. Or if there is hyperprolactinemia, add cabergoline. So these are the drugs I would like to recommend, which I am also using. For patients with idiopathic disease, symptomatic management with a drug or a combination of drugs aimed at more than one therapeutic target may be an optional choice. And selection of drugs should be tailored to need of individual patients and specific circumstances. Generally, a drug treatment does not always produce normal ejaculation, but it may enable partial antegrade ejaculation or retrograde ejaculation. So if the patient has come with infertility issue, then the treatments are different. Number of approaches can be employed. Simplest approach is to collect the nocturnal emission in a spermicide-free condom or for assisted reproduction. Or you can go for other types of ejaculation through vibrator or through vigorous prostate massage or prostatic urethra catheterization and collect the semen. So presence of spermatozoa in the prostatic urethra may be due to ejaculation dyssynergia. Assisted ejaculation in the form of a penile vibrator device is the next choice of sperm retrieval in idiopathic AE. And if necessary, you can go for the TISA, MISA, and PISA. It requires intact lumbosacral cord segment only when the sensory nerves are normal, then only the penile vibratory sensory sensation therapy works. Coming to adverse effects of profile of these procedures may include skin irritation, high blood pressure, rectal mucosa burning, and autonomic dysreflexia, which can be pre-treated with 10 to 40 milligram of sublingual nifedipine approximately 15 minutes prior to the penile vibratory sensation therapy, which can blunt the increase in blood pressure in men with a history of systemic sclerosis. In the vast majority of these men, motile spermatozoa can be obtained through assisted ejaculation. When such procedures fail, sperm retrieval through either percutaneous basal sperm aspiration or minimally invasive epidermal sperm aspiration, that is TISA, MISA, PISA, may be done. Ejaculate samples retrieved from men with systemic sclerosis typically are characterized by normal sperm concentration but abnormally low sperm motility. The literature is coming to the end of this one. To conclude, the literature suggests that pathophysiology of DE is multifactorial, including both organic and psychosocial factors that are neither independent nor mutually exclusive. Despite the many publication on this condition, the exact pathogenesis is not yet known. There is currently no single gold standard for diagnosis of DE, as operationalized criteria do not exist. The history is the key to that analysis. Treatment should be cause specific. There are many approaches to treatment planning, including various psychological interventions, pharmacotherapy, and specific treatment for infertile men. No approved drug exists right now. A rigid treatment plan is not suitable for all the patients. A number of approaches can be employed for infertile men, including collection of nocturnal emission, vigorous prostatic massage, prostatic urethra catheterization, penile vibrator sensation therapy, rectal probe ejaculation, sperm retrieval from either vas deferens or epididymis or testicular sperm extraction. So the treatment depends upon whether the patient with the DE has come for the treatment of the reaching the orgasm or the patient has come for infertility. If the patient has come for infertility treatment, then various methods of sperm extraction are available and they can be used so that the patient will get the relief. That is, he will be successful in getting a pregnancy through various other techniques. So, friends, that was about the management of the sexual dysfunction. That is, today I have covered mainly the delayed ejaculation. In the next lecture, I'll be taking the ejaculation and, if possible, painful ejaculation also combined. I will take up in the next lecture. Regarding the premature ejaculation, I have already covered. So, the sexual dysfunctions include premature ejaculation, delayed ejaculation, unejaculation, retrograde ejaculation, painful ejaculation. So premature ejaculation has already been covered, as I told you. Today I have covered delayed ejaculation. The other three I'll cover in the next 1 or 2 lectures. So thank you very much for your patience listening. I sincerely thank for us and his team and the IGCP authorities for giving me an opportunity to address you. I'll be very happy to answer any of your questions. Since the topic is rarely discussed, it requires a lot of time to understand the causative factors and the treatment aspect of the delayed ejaculations. So I request all the doctors who are participating to restrict your question to delayed ejaculation today so that other questions we can take up appropriately when we discuss the other topics. Thank you very much. Over to Faraz.
Thank you so much, sir, for wonderful session, sir, and it was very helpful. I hope this session knowledge is going to help all the participant during this practice also, sir. Sir, as I can see, sir, there is no more question. I hope that you have done justice to this topic and the concepts are clear so that people like audience have no any doubts regarding to this topic, sir. And we have two feedback from for
Yeah.
Dr. Anupma. She's writing wonderful session, and
Mm.
another from Dr. Ashwarya Sambhati from Chennai, and she's writing wonderful presentation and great to have a lecture from you.
Oh, thank you. That means the lecture is complete. But
Yes, sir.
the only thing is, since this is a very new topic and rarely discussed, naturally the questions will also be less because hardly people who are in the general field treat the conditions like delayed ejaculations. Patients with delayed ejaculation only land up with an andrologist or a urologist or sexologist. Usually they don't go to a general physician or a general doctor or a gynecologist because this is a rare condition. So only about 5% of the men with sexual dysfunction have DE. That shows that it is not a frequently seen condition. Whereas premature ejaculation and erectile dysfunction are seen in each 40% erectile dysfunction, 40% premature ejaculation in patients with sexual dysfunction. So when you take people with sexual dysfunction, what we usually see are erectile dysfunction, premature ejaculation, and small penis syndrome. So these are very commonly seen. And Cases like delayed ejaculation, only about 5%, anejaculation, about 5%, retrograde ejaculation, about 5%, and painful ejaculation, about 2 to 3%. So all these four together, they do make up only 20%, whereas 80% is made up from the erectile dysfunction and premature ejaculation. That's why the topic today, which we have discussed, is not that frequently seen in the general practice. Only they are seen by the andrologist or urologist or sexologist who are practicing every day the sexual medicine. So thank you very much for us for giving an opportunity to address my beloved esteemed doctors. And I sincerely thank for the nice feedback of those doctors who have given their feedback. That inspires us to prepare more and more for the next coming session, so that we'll be happy to share our knowledge in the field of sexual medicine, which we are doing from past several decades. So whatever I'm speaking, it comes from my experience as well as the practical things which we have seen day to day. So the outcome of the lecture is not just theoretical one, but that comes from the in-depth knowledge of the practical experience from the day-to-day clinical practice. So thank you very much. Shivratri. Good night.
Bye, sir. Take care, sir, and hope to see you again in future also with different topics, sir.
Yeah,
Have a
thank
great
you.
day. Bye.
We can take up the other two which I have told. That is retrograde ejaculation.
Yeah, sure, sir.
And yeah, so that you know, I already have told that I have not covered those.
Okay, sir. Sure, sir, in
Okay.
future, sir. Thank you so much.